con el programa de presentaciones. Es para mí todo un gusto presentarles al doctor Hess. El doctor es Assistant Director of Respiratory Care en el Departamento de Anestesia, Medicina Crítica y Medicina del Dolor del Hospital Mass General. Él nos va a presentar Inhaloterapia en ventilación mecánica.
Well, it's good to be back in Mexico City again to be part of this meeting. I have attended this meeting as a speaker a number of times, and I'm always happy to be invited back because I learned very much from being part of this meeting. In this morning's presentation, I will be talking about aerosol delivery during mechanical ventilation and how we can deliver inhaled bronchodilators, vasodilators, antibiotics, and a bit more. These are my disclosures. I do not believe that any of these impact what I will talk about this morning, but I will allow you to be the judge of that. There are a number of drugs that we can administer by inhalation today during mechanical ventilation. These include bronchodilators, steroids, mucokinetic agents, antibiotics, vasodilators, and I'm sure that in the future there will be other agents that will also be available for inhalation during mechanical ventilation. There are a number of aerosol delivery devices that we might use. These include the nebulizers, which can either be a jet nebulizer or an ultrasonic nebulizer or a mesh nebulizer. We can use meter dose inhalers, and I will talk about nebulizers and meter dose inhalers in some detail over the next several minutes. We cannot, during mechanical ventilation, use a soft mist inhaler like the Respimat or a dry powder inhaler because these devices currently are not available to be used in a ventilator circuit. However, there are prototype devices under development to allow the use of the soft mist inhaler during mechanical ventilation, and I'm sure we'll learn more about that in the near future. There are a number of factors that affect aerosol delivery during mechanical ventilation. These relate to the ventilator and how the ventilator is set. These relate to the ventilator circuit, things such as the endotracheal tube and whether or not we humidify the inspired gas and the density of the gas. There are issues related to the inhaler, if we use an inhaler to deliver the drug. There are issues related to the nebulizer. We'll talk about these in more detail over the next several minutes. There can be issues related to the drug formulation, and then there can be issues related to the patient. The traditional way to deliver aerosols during mechanical ventilation was with the use of a jet nebulizer. And I suspect that around the world, even today, the jet nebulizer is very commonly used to deliver aerosolized medications during mechanical ventilation. But it's important for us to appreciate that there are a number of factors that affect aerosol delivery when we use a jet nebulizer. These include where the nebulizer is placed in the circuit, the type of nebulizer and fill volume, the presence or absence of a humidification device, the carrier gas, such as a low-density gas like Heliox, the treatment time, the inspiratory time, whether or not the nebulizer is breath actuated, whether or not we use pressure control or volume control ventilation, and the ventilator brand. So there are many issues then that we need to think about when we deliver aerosols by jet nebulizer during mechanical ventilation. And some of those I have illustrated on this cartoon. For example, if we increase the inspiratory time setting on the ventilator, that will increase the amount of drug that is delivered. If the nebulizer is breath actuated, so that the aerosol is only delivered during the inspiratory phase, that will increase the amount of drug that is delivered. If we use a heat and moisture exchanger or an artificial nose, that needs to be either removed or bypassed during the treatment because the heat and moisture exchanger can be a very effective filter of the aerosol. If we move the nebulizer further away from the patient and closer to the ventilator, that increases the amount of aerosol delivery. If we deliver the aerosol into a dry gas, in other words, take the humidifier out of the circuit, that will increase the aerosol delivery. However, I do not recommend that because it will have a drying effect on the lower respiratory tract of the patient. Not sure what this is. And if we use a lower density gas, such as heliox, that will increase the drug delivery, but that is technically more difficult, and I generally do not recommend that. I will talk a little bit more about that tomorrow when I talk about different gas delivery, different types of gases that we can deliver during mechanical ventilation. It's also important to appreciate that there are a number of potential problems with the use of jet nebulizers during mechanical ventilation. With a jet nebulizer, it's easy to contaminate the ventilator circuit and then contaminate the lower respiratory tract of the patient, and in that way be a cause of a ventilator-associated pneumonia. With a jet nebulizer, we increase additional flow into the ventilator circuit, and that can increase the delivered tidal volume and the airway pressure. The additional flow from the nebulizer into the ventilator circuit can make it more difficult for the patient to trigger the ventilator. The aerosol can damage the expiratory transducer in the ventilator, so that often filters are placed at the outlet of the ventilator circuit to protect the transducers in the ventilator, and if we use oxygen or air to power the nebulizer, that can affect the FiO2 that the patient receives. To get around these issues with the use of jet nebulizers during mechanical ventilation, increasingly mesh nebulizers are used. Mesh nebulizers produce the aerosol by forcing the liquid through a very fine mesh that breaks the liquid into an aerosol that can then be inhaled by the patient. With mesh technology, there is a predetermined particle size determined by the size of the holes in the mesh. There are no propellants. There is no additional gas flow that is added into the ventilator circuit. There's very little dead volume, meaning that virtually all of the drug that we place into the nebulizer is delivered to the patient, and there is a very high rate of aerosol production. So we get around many of the issues with the jet nebulizer by using a mesh nebulizer, and this is increasingly used throughout the United States and I suspect around the world. This is a picture of the mesh nebulizer in line in the ventilator circuit. The mesh nebulizer here is at the inlet of the humidifier. In other words, it's closer to the ventilator, further away from the patient, and this has been shown to very effectively deliver aerosols during mechanical ventilation, and again overcomes many of the issues with the use of a jet nebulizer. We can also use a metered dose inhaler during mechanical ventilation, and it was shown many years ago, this study published more than 20 years ago, that if we aerosolize 4 puffs of albuterol by metered dose inhaler into the ventilator circuit, that can result in a significant reduction in airways resistance. So 4 actuations of albuterol from a metered dose inhaler into the ventilator circuit can significantly reduce airways resistance. And notice that with the additional number of actuations, 8 or 16 additional actuations, there was no further reduction in airways resistance. So this would suggest that if you use a metered dose inhaler to deliver albuterol, a bronchodilator, during mechanical ventilation, 4 actuations is likely sufficient. It's also important to appreciate that how we adapt the metered dose inhaler into the ventilator circuit is important. And it's been shown in many studies, dating back now almost 25 years, that if we use a metered dose inhaler, we should introduce the aerosol into the ventilator circuit using a spacer device rather than a non-spacer device. So there's significantly more aerosol that is delivered with the use of a spacer device. Now, a question that is asked clinically at the bedside, well, which is better? Which should we use? Is it better to use a nebulizer, or is it better to use a metered dose inhaler? Is one superior to the other? This was addressed in some clinical practice guidelines published now more than 10 years ago that concluded that both nebulizers and metered dose inhalers can be used effectively to deliver beta-2 agonist bronchodilators to mechanically ventilated patients. However, careful attention to details of the technique employed for administering drugs by metered dose inhaler or nebulizer to mechanically ventilated patients is critical, since multiple technical factors may have clinically important effects on the efficiency of aerosol delivery. So in other words, it's not so important whether you choose a nebulizer or a metered dose inhaler. What is important is that you use the correct technique with the device. Now, if we look at the correct technique for the use of a nebulizer versus a metered dose inhaler, you can see that there are many more things we need to pay attention to with a nebulizer, with a jet nebulizer, than with a metered dose inhaler. So this would then suggest that it may be preferable to use a metered dose inhaler because there are fewer ways that we can make mistakes. However, at least in the United States, a big problem with the use of metered dose inhalers is that they are quite expensive. And they are more expensive than solutions that we can place into the nebulizer. And it's important then to appreciate that many of these issues with a jet nebulizer are overcome with a mesh nebulizer. And now it has become increasingly common in the United States, and I suspect other places around the world, to use a mesh nebulizer to overcome a lot of the issues with a jet nebulizer and to avoid the high cost associated with a metered dose inhaler. But again, what is most important is attention to proper technique. So then if we think about whether we use a nebulizer or an inhaler during mechanical ventilation, an inhaler is acceptable, I think, for routine bronchodilator therapy. A nebulizer, however, is superior to an inhaler when a large dose is required. It's easier to deliver a large dose of bronchodilator with a nebulizer than it is with a metered dose inhaler. The mesh nebulizer is cost-effective, and it eliminates many of the issues associated with the jet nebulizer. Now, up until this point in the presentation, I've talked about aerosol delivery during invasive mechanical ventilation. Can we deliver aerosols during non-invasive ventilation? And the answer to that is yes, we can. And there are various approaches that we can use to deliver aerosols with non-invasive ventilation. One is to remove the patient from the ventilator and administer the bronchodilator or other aerosol in the usual way by nebulizer or metered dose inhaler. However, that approach is usually not satisfactory because it interrupts the delivery of non-invasive ventilation. So that's not the technique that I generally recommend, because it means that the patient who might need non-invasive ventilation has that therapy interrupted. We can administer nebulizer therapy in line during non-invasive ventilation using either a jet or a mesh nebulizer, and available evidence suggests that either can be effective, or we can administer aerosols during non-invasive ventilation using a metered dose inhaler in line. On the slide, you can see on the left a metered dose inhaler attached to a chamber device attached to an oronasal mask. In the picture in the center, you can see a nebulizer attached directly to the oronasal mask, and on the right is shown a mesh nebulizer incorporated into the oronasal mask for non-invasive ventilation. A point that I would make here is that when delivering aerosols during non-invasive ventilation, the correct place to position the nebulizer or the inhaler is directly at the mask. And a number of studies, including some that I've done in my own laboratory, have shown that that is the best place for the aerosol generator, the nebulizer or the inhaler. So then, regarding aerosol delivery with non-invasive ventilation, available evidence supports that aerosols can be delivered effectively during non-invasive ventilation. Avoid leak of aerosol into the eyes of the patient, so make sure that the mask is fitted correctly so that aerosol does not accidentally get into the eyes of the patient. And evidence is currently not sufficiently robust to recommend routine use of non-invasive ventilation for aerosol therapy. So I would not recommend the use of non-invasive ventilation solely as a way to enhance the delivery of aerosols. But if a patient is already receiving non-invasive ventilation, then the use of aerosol therapy can be added to that quite effectively. Now let me switch the focus a bit and let's talk about selective pulmonary vasodilators, in this case with the delivery of an aerosolized prostacyclin during mechanical ventilation. This is something that has received a lot of interest throughout the United States in recent years, primarily as an alternative to inhaled nitric oxide, which is quite expensive. And tomorrow in my presentation, I'll talk in more detail about inhaled nitric oxide. But we can deliver an inhaled pulmonary vasodilator, most commonly a prostacyclin, by aerosol. That aerosol is selectively delivered to the ventilated parts of the lung. That improves blood flow to the ventilated parts of the lung, and that way improves the ventilation perfusion matching within the lungs. That may have a beneficial effect on arterial oxygenation, and because it is a vasodilator, can have a beneficial effect in pulmonary artery pressure. This is from a meta-analysis published a few years ago, looking at the use of inhaled prostaglandins or prostacyclin in patients with ARDS, and what was concluded from this meta-analysis is that indeed the delivery of a selective aerosolized pulmonary vasodilator improves oxygenation in patients with ARDS. And in this study, it was a significant improvement in arterial oxygenation. So it can improve ventilation, perfusion, matching within the lungs because the aerosol is selectively delivered to the ventilated part of the lungs, which improves blood flow to that part of the lungs. In the same meta-analysis, they also showed that that was associated with a reduction in pulmonary artery pressure. So the degree of pulmonary hypertension was improved. However, they also found that in almost 20% of patients, in about 1 of 5 patients, there was hypotension that was reported. And that's because the aerosolized prostacyclin or prostaglandin that we deliver into the lungs may pass across the alveolar capillary membrane into the bloodstream. There may be uptake of the drug by the pulmonary circulation, resulting in downstream systemic hypoventilation. I think it's also important, and perhaps most important, to point out that to date there have not been outcome studies comparing the use of a selective inhaled pulmonary vasodilator to placebo that has shown an important improvement in outcomes such as in mortality. So we do not know if the effects of the aerosolized prostacyclin, which improves oxygenation, causes some reduction in pulmonary artery pressure, we do not know that that translates into better patient outcomes. Now, I just wanted to say a word about aerosolized antibiotics. There is interest, I think, worldwide in delivering antibiotics by aerosol in mechanically ventilated patients. This is something that has been discussed for virtually my entire career. Back in the 1970s, there was discussion about aerosolizing antibiotics, and there was some aerosolization of antibiotics back 45, 50 years ago. And there continues to be interest. To my knowledge, this is the largest study to have been done to date. The results have not yet been published, but they are, I think, fairly well known. This was a prospective randomized double-blind placebo-controlled multi-center study that was conducted in a number of countries around the world to evaluate the safety and efficacy of inhaled amikacin as an adjunctive therapy in intubated, mechanically ventilated patients with gram-negative pneumonia. And the bottom line was that this study, which was very large, took a number of years to complete, was unfortunately a negative study. And I think that is unfortunately an issue that has occurred with a number of studies of aerosolized antibiotics. And when studies like this are negative, the question that arises is, well, why did the study fail? So why was this study, which I think was a very well conducted study, why was it a negative study? And some would argue, well, they didn't use the right drug. So there's some debate about whether amikacin was the right selection of drug in this study. Or maybe they used the wrong dose or the wrong dosing scheme. Maybe they selected patients where the disease wasn't quite right. Or maybe some have argued, well, the delivery system wasn't very good. But I can tell you, I know a lot about the delivery system that was used in this study, and the investigators tried very hard to address virtually every one of those issues that I talked about earlier in this presentation about technical problems with aerosol delivery. I think a question that we need to address is that, or an issue that we need to address is that perhaps inhaled antibiotics are not effective. There have now been a number of studies over the years that really haven't been as, started out with a lot of optimism, and then, like this study, turned out to be negative at the end of the day. So in summary then, aerosols can be effectively delivered during invasive and non-invasive ventilation. We do need to pay close attention to correct technique. So regardless of the device that we use, whether it is a jet nebulizer, a mesh nebulizer, a meter dose inhaler, we need to pay close attention to technique. And I think additional study is needed for aerosolized vasodilators and inhaled antibiotics during mechanical ventilation. I'm not ready to give up on these therapies. However, I think that there is additional study that is needed before we can, I can recommend embracing these therapies. So with that, I've reached the end of my presentation, and it looks like we have a few minutes for questions, which I'm certainly happy to address any questions that you might have. Thank you.